Hello, my name's Max Katie. I'm a consultant urologist at Lancashire Teaching Hospitals in Preston, and I am hosting this particular session with my colleague, Miss Moore, who will introduce herself.
Hi, I'm Katie Moore. I'm also a consultant urological surgeon based at Manchester Royal Infirmary, which is part of Manchester Foundation Trust. We are between us talking about e-poster section 3, which is the trauma and general urology section.
Right, I'll introduce the first poster. This is a poster from University College London, and it's entitled Investigation of Patients with Hematospermia, How Common is an Underlying Diagnosis in These Patients. Essentially, they looked at hematospermia in just shy of 400 men over a period of about 18 years. And in this group of patients, the headline is that they found prostate cancer in a significant number, and we'll come to that in a bit. The aims were essentially to evaluate the diagnostic yield of investigations undertaken to investigate hematospermia, and then to tell us whether there was a significant incidence of underlying pathology. And certainly in my experience, most of these patients have no pathology, but it's very difficult to come to statistics, and therefore this is an important paper in that respect. They looked at patient demographics, and they also did quite a lot of different investigations. It's not absolutely clear why, but they did various investigations, including an MRI, PSA, obviously clinical examination as well, and then produced an algorithm at the end to describe how you might manage these patients and investigate them in a sensible and systematic way in order that we can practice safely and also pick up those patients who have any significant pathologies. Now, in terms of the conclusions, the overall rate of prostate cancer in this particular series was 5.6%, which is essentially 22 men out of the 393. And other pathologies were found, and I'm sure Katie will have something to say about the types of pathologies that were found when we come to the discussion of this paper. The bottom line, however, is that there is a significant number of patients who have significant pathology who present with hematospermia, and therefore it has to be taken seriously. And this poster provides a good algorithm for managing these people. Katie?
Yeah, I mean, I'd agree. I'm on call this week and going to the advice and guidance, which is the way in Manchester, the GPs contact us initially. There was 7 hematospermia. What do I do? Do I refer? Actually, we could follow this algorithm, suggest that they have their PSA checked, a urine dipstick, and a rectal exam, and then you can filter those that need further investigation for suspected prostate cancer. They did find in this study, they found 1 bladder cancer case and 1 testicular cancer case. I suspect that testicular cancer case was just coincidence and not related to the hematospermia at all. They did mention other findings. I think they talked about some other findings that was other pathologies that were suitable for intervention, and they haven't made it clear whether it was other findings suitable for intervention or other findings that actually needed intervention. So was it actually symptomatic findings that they found? But they did find pathologies that they went on to intervene for, such as blocked ducts, that they did some sort of intervention for their blocked ducts. But so I think that algorithm is definitely something that I will now be following, or for the advice and guidance from GP suggesting that they follow as well.
It certainly speaks to the fact that it's certainly in my experience that these people come to us because most of them are actually worried about cancer. They see blood in the semen, and the first thing they think is, I've got something dreadful going on. And the important thing, I think, is a proper evaluation of the patient, which this, I think, addresses, which is take a proper history, examine the patients, including a testicular examination and a rectal examination, and consider other pathologies, particularly prostate cancer in this situation, because in this particular group of men, 5.6% of them had prostate cancer. There are also bladder pathologies, and interesting as well was that there was a significant, I forget the actual number, amount of concomitant visible hematuria in these patients, which is an interesting finding. I think it was higher than we thought. I think it was 24%. 24% of patients had a history of concomitant visible hematuria. That's quite a serious thing, because a serious finding, because it means a quarter of these people would need investigating anyway for hematuria. So the point, as you say, is if someone has persistent hematospermia, or any kind of hematospermia, they need at the very least a full history and a full clinical examination in order to determine what to do for them.
I would definitely agree.
Yeah. The only other thing was there seemed to be a big number of them who went on to multiparametric MRI. I don't know whether that is a local practice or something else.
Whether they all came back with raised PSAs to trigger that, I don't know. It's not really clear from what triggered the multiparametric MRI.
Yes. However, it does not change the conclusion, which is that these people need to be taken seriously and have a proper evaluation. And in fact, most of the things that they describe can be done in one visit.
Yeah.
If the patient comes and they've already had a PSA, the clinical examination and all the other things can be done in one visit. And most of them can be discharged from there, and a few of them will then have to go undergo investigations depending on those clinical findings.
Absolutely.
Yeah. Okay.
So the next poster is for the team at Royal Berkshire, and they looked at ultrasound guided suprapubic catheterization technique, outcomes and cost effectiveness, and they were comparing it to traditional cystoscopic guided suprapubic catheter insertion performed in operating theatres by the urology team. It was a retrospective study looking at consecutive patients. It's not clear how they chose which patients underwent the ultrasound guided insertion versus the cystoscopic insertion, and there were more having the ultrasound guided, so 124 ultrasound guided versus 31 cystoscopic guided. For the ultrasound guided techniques, they had to have a urethral catheter inserted, so they did need to have a patent urethra, and the bladder was filled retrospectively, and then the ultrasound was used to guide using a Seldinger technique with a guide wire, the suprapubic catheter insertion. And they looked at technical success, clinical success, 30-day complication rate, and then a cost effectiveness ratio. The two comparison groups, although there were different numbers, the statistics of the sort of demographics of the groups were fairly similar. And they concluded that the results had similar success rates. The complication rates were low in both groups, though slightly higher in the cystoscopic group, but that they admitted that probably was because that group stayed overnight, I guess because of the general anaesthetic, and because they stayed overnight, they were more likely then to pick up complications such as infections. But they also found that the ultrasound guided insertion was significantly more cost effective, I think obviously because they didn't have the cost of theatre, general anaesthetic and an overnight stay. So yeah, probably something should we be changing our practice? If somebody needs an elective suprapubic catheter insertion, should we be going down the route of a radiology guided procedure rather than bringing them into theatre and doing it that way?
I agree that it's an important question as to how you should be doing this. I think certainly in my hospital, most of these patients are dealt with on the ward with ultrasound guidance on the ward done by ourselves rather than anybody else. In other words, you make sure that the bladder is full as per Bausch guidance. So I'm not entirely sure that it needs necessarily for the radiology department to be involved, which seems to be the case here, but it's not a criticism, it's just the way they do theirs. They involve radiology, or seemingly they involve a radiology. The thing that struck me on this is on the results tab of the poster, the complication rate, it says major complications, and whether it's my eyes or something else, it seems to suggest that the major complication rates were in the region of 15% for cystoscopy guided and 10% for ultrasound guided. I'm not quite sure what those major complications were. It seems a little bit high. I don't know if you noticed that.
Noticed it. No, I didn't catch that, but yeah, that does seem high actually.
But if you look at the results thing at the bottom, the middle column says major complications.
Oh, yep.
Sorry?
Yep, I'm seeing that now. Major complications, yep, but it's not referenced there in the.
And minor complications as well are quite high at 40% for what is a pretty straightforward procedure. So I'd quite like to know what it is that these complications were and what they consider a major complication, because to my mind, a major complication for suprapubic catheter is things like bowel injury or hemorrhage, or also the sort of things that cause morbidity. And in my experience, suprapubic catheter insertion, particularly using these techniques that they describe, is a very safe procedure. Yes, with the potential for very serious complications, but I don't recognize 15% major complications in my practice.
No, and I would agree with that. The other thing is, I'm not convinced that for me personally, with my skill, that I would be able to recognize bowel. Would I be able to recognize bowel with an ultrasound? I can recognize a full bladder. Mm-hmm. The sort of ultrasounds we have access to on the ward, that's why we probably in our trust would use a radiographer to do an ultrasound guided SPC insertion if that's what we were doing. But we tend to, at the moment, still use a general anaesthetic SPC insertion if we're having an elective SPC.
I think there is variation in practice, and certainly from where I stand, if there's any doubt, then. But yeah, if there's any doubt, of course you would ask a radiologist to have a look. But in the standard normal situation where a patient comes in and we cannot catheterize them on the ward, they have a virgin abdomen. We follow the standard guidance, which is do an ultrasound to check that there is a full bladder, and obviously a clinical examination check there's a full bladder. In which case you would then put a suprapubic catheter on the ward, and that's where most of ours happen. In someone where there's doubt or there's difficulty because they've had previous surgery and so on, then I would always ask a radiologist.
Yeah.
Now, the next poster is an interesting one. It is out of Southampton. It is entitled "The Role of Cannabinoids in Benign Urological Disease as it Relates to Both Basic Science and Clinical Practice, a Systematic Review." The title is quite a mouthful, and this is borne out by the breadth of the poster itself. Essentially, this is a literature review looking at various papers relating to urology in what is now essentially the cannabinoid literature. Their aims are stated as to determine how cannabinoids behave within the urological system, to determine how cannabinoids are currently used in the treatment of benign urological pathologies and the clinical value of this information, and also to establish which cannabinoid-based treatments show the most promising results. They essentially looked at hundreds of papers. I think it was 771 papers which were identified, and out of these, 62 were deemed relevant to this particular study. Many were excluded because there was lots of duplication. There was also some from what I think was termed the grey literature, in other words, not peer-reviewed literature, and also lots with wrong patient populations found. The discussion is not particularly specific, and I found it difficult to interpret this. It essentially just described what they'd found in the literature, and I think the bottom line from my point of view is that the literature on cannabinoid use in urology is pretty confused, and there isn't very much yet that we can latch onto as the gospel, as it were. There's much more material in this area that is promising and shows promise, in particular in pain and so on, pain management and so on, but not anything that we can latch onto just yet. I don't know what you felt, Katie.
Yeah, I think the sort of one of the conclusions I took away was it is used a bit in human practice, but a lot of the studies were animal related, and there's nothing really that concludes whether it could be translated into human clinical practice yet. It might show promise, but there doesn't seem to be any conclusive evidence of that yet.
I think there's value in that conclusion as well, which is to say, look, this is a potentially exciting area, but let's not get too excited just yet. And the poster does outline the potential areas of interest. But in the end, I think from my point of view, I'd say, yeah, watch this space. I am not going to be using cannabinoids in my practice for some time yet, until this particular area is clearer.
I thought it was interesting. They said one of the conclusions was it may reduce the likelihood of developing urinary symptoms in men.
Mm-hmm.
Is that obstructive urinary symptoms, or is that irritative urinary symptoms? And if it is irritative, is there any reason why that can't translate to women as well?
Again, as I say, the conclusions are vague, partly because
Yeah.
I suppose the breadth of the paper, but also it's very frank admission that this area is confused.
Yes.
There's a lot going on. Having said that, I've had patients who've asked me about cannabinoids and whether their symptoms could be alleviated by this. So this is not going away. We're going to see more and more of this kind of work, but also hopefully more specific papers addressing specific symptoms in urology.
I feel like cannabinoids is one of those things that it does seem to wax and wane. It did become quite fashionable sort of 10, 15 years ago, and then went quiet for a bit, but now does seem to be coming more to the fore again. So maybe this time there will be some more active continued interest if more positive outcomes come out of it.
It's one of those things that follows trends, almost certainly because it has come out of, obviously, substance abuse and other things, and people are trying to find out how useful this could be in medicine. And I find, certainly amongst my patients who've asked me about this, that they give this particular group of drugs all sorts of supernatural powers that they don't necessarily possess.
Yeah.
Okay.
So moving on to the next paper, which has come out of Norfolk and Norwich, Are Adults Just Big Kids, which is kind of a catchy title, a collaborative approach to the management of vesicoureteric reflux in adults, a case series and systematic review. So this basically is looking at vesicoureteric reflux in adults. It's very common in children, and in children can resolve by itself or can be managed endoscopically. Vesicoureteric reflux is much less common in adults and can be quite problematic to manage without major intervention, which can come with significant side effects. So this was a retrospective analysis over 10 years of only 7 female patients. And I'm not quite sure what really to make out of this, really. They had 7 patients with recurrent UTIs and pyelonephritis, and all were presumably confirmed to have vesicoureteric reflux. 2 had previously had bilateral ureteric reimplants as an attempt to manage their ureteric reflux. So as an attempt to further manage all these patients, they all had deflux injections. 4 had just 1 injection and 3 required more than 1 injections. And it states in their results that symptomatic improvement ranged in duration from 9 months to 6 years. But 2 patients continued to have recurrent urinary tract infections after their deflux injections, and 2 patients had continued reflux on their post-operative or post-deflux injections MAG3 scans. Whether that was symptomatic reflux, I'm not too sure. But no patients went on to develop evidence of obstruction, and no patients had reimplantation. So their conclusion is that you could use endoscopic management of vesicoureteric reflux because that avoids the morbidity associated with the extensive abdominal surgery with ureteric reimplant. And that's pretty much it, really. So it's a small case series, but it's going to be small if it's come from one institution, because vesicoureteric reflux is small numbers in adults.
Mm-hmm.
Does it add anything to the management of vesicoureteric reflux?
I think it's too small. I think
too small, yeah.
It's over 10 years as well, and retrospective. So there are several weaknesses just in that. I do recognize that this is a sort of data that's really hard to come by.
Yeah, absolutely.
Precisely because this is a rare situation. The other thing was I didn't quite work out how the vesicoureteric reflux had been worked out. There is mention of MAG3 in MAG3 scanning in 2 of the patients, but of course, vesicoureteric reflux can be determined by all sorts of other things. Video urodynamics, for example, can show you vesicoureteric reflux. It can be on cystography during an operation. You can, there are other ways of working this out. So I don't know whether there was a standardized way of working this out such that these patients were then comparable. The other thing that's a weakness in my view was the age range was very wide. There's 19 to 54, so there's a whole group of people here. And
this,
sorry?
To me, it was a symptomatic improvement range from 9 months. Does that mean one patient was only improved for 9 months, or does that mean that was the patient that was looked at in 2019, so they could still be improved now?
Yeah. Again, a little bit confused as to what that means. And finally, they do mention that 4 patients required 1 injection, 3 required more than 1 injection, 2, 3, 4, 5 injections, several injections. What were the indications for giving these other ones more injections? And if they've required more than 1 injection, are they still comparable to the ones that required only 1 injection? It's because of the small numbers, this is a difficult study to come to any reasonable conclusions about. I wonder whether some sort of collaboration, perhaps to increase numbers with other units, might be a useful thing here to take this work forward, to work out whether essentially they're managing recurrent infections and recurrent pyelonephritis in this way is the right way to go.
That's what I was about to say. Could this be something for the BSOT group to take forward? Because that's all registrars working together across the country, isn't it? Could that be something that they could undertake in the future?
Yes, to see whether it can only ever be retrospective, unfortunately, but yeah. They certainly need bigger numbers to work out whether any of the conclusions are substantial. Okay. The next one is a paper from Bolton and Manchester, and it's about delayed presentation with acute scrotal pain in ethnic minorities. Essentially, it asks a very simple question, which is there a delay in presentation of suspected torsion in patients from ethnic minorities? A retrospective audit was taken in patients from 2014-2019, and they essentially used patients' ethnicity data from the notes to work out who was ethnic minority and who was white British. There were 29 ethnic minority patients who presented with suspected torsion in this particular study, and 65 from a white background. In patients found to have torsion with or without testicular loss, ethnic minority patients presented with a median 17.5 hours compared to 3 hours for white British patients, which is clearly very significant, clearly very significant difference. P-value was less than 0.001. And they calculated that the relative risk of an ethnic minority patient requiring orchidectomy when presenting with torsion was 12.83. Their conclusion is that in their population, ethnic minorities present later with acute scrotal pain, increasing their risk of testicular loss. They conclude that more study is required to identify the causes of delayed presentation in these patients with the aim of improving health education. They are apparently trying to develop an educational literature to attempt to combat this health inequality.
Yeah, and I think in this paper as well, if you drill down the statistics a bit more, in the white British group, 33 out of the 65 testicular pains had torsion, which is 51%, and 18 out of the 29 from the ethnic minority group, which is 62%, were tortured. So the actual torsion rate was higher in the ethnic minority group compared to the white British group as well. So it'd be interesting to see if there is any reason why the ethnic minority group appear to be or are presenting later, and is there a reason why they seem to have a higher torsion rate as well? Are they presenting later because of a lack of education, a lack of understanding? Do they present to an out of hours first, and is there a language barrier there to then prevent them being referred on to the secondary care service? Do we need to have more literature out there in a variety of different languages to get the message across that if you have acute severe pain, you need to seek emergency medical attention?
Absolutely. It's a very, very important paper because it highlights in very stark terms. I mean, a relative risk of 12.83 is, it's a big difference. And also the rate of testicular loss in the ethnic minorities is high. There are a couple of questions for me, which, what do they mean by ethnic minority? Because there are many different ethnic minorities, and it may be that there's a specific cultural issue in one of those ethnic minorities that's causing the problem. It may be the ethnic mix in that particular area of the world that is the cause of the problem. I think whatever the cause, there's clearly an issue. The conclusion of the study that more work is required, I think, is absolutely appropriate. I think education is probably a very important part of this. But first of all, we need to establish who the ethnic minorities are specifically in order to target that education properly. I think this is a very good paper, which is very simple and asks a very important question.
I think the education needs to go not only to the different ethnic minority groups, but also to the clinicians that will be seeing all these types of people as well.
Absolutely. I mean, if as a clinician you know that this is a particular issue, you would pay more attention, and that's important to remember.
And maybe in accident and emergency, we should have more leaflets there, more of these sort of pictorial diagrams, particularly now as it's more and more difficult, we're finding, to get hold of somebody on Big Word, because Big Word is because that's what we use for our translational service. They're so clogged up because you can't get interpreters. You're waiting 20 minutes, and that's 20 minutes of testicular time waiting.
Yeah, absolutely.
So moving on to the next paper, it's a joint presentation that's been put together by the Hurston Biofabrication Institute and Redcliffe Hospital in Queensland in Australia, and they're looking at 3D printing to improve testicular prosthesis prototypes using a lattice infill structure to modify mechanical properties. So they wanted to produce a 3D printed testicular prosthesis that would be more like the natural feel, size and shape of a real testicle compared to the ones that we commercially use nowadays. They used various different techniques that way beyond my level of understanding to produce a prototype 3D printed testicular prosthesis and compared it to ones that are available. And they looked at specific properties, the stiffness and hardness. And they found that the one that they were able to develop is much more like much more able to match the properties of a human testis compared to the ones that we are using nowadays when we're inserting a prosthesis. And the conclusion was, though, that the one that they have created can only be limited to short exposure to human tissue. So to my mind, that means it can't be used in situ at the moment. So I think this is very much something that's in development, something that still needs ongoing testing, but hopefully in the future with these types of new technologies, we'll be able to develop and create individualized patient implants, be that testicular prostheses or other type of prostheses that are used that would specifically match an individual's patient's needs in terms of its shape, size, and mechanical properties that are required.
I think any urologist who's used testicular prosthesis will say absolutely they never feel like a normal testis.
No.
And we all sort of get whatever's on the off the shelf. There's usually 2 or 3 sizes available, so you kind of work out what's best, but it never matches the other one properly. I think it's important to remember that the sorts of people who have testicular prosthesis are generally quite are vulnerable. In the sense that they are already very aware of the fact that there's an abnormality there. They're already very aware that someone might think differently of them if the testis feels different or looks different, and therefore it is important that whatever prosthesis we put in is as good a facsimile as we can make. So this sort of work is not only interesting, but it's important. Like you, I wonder whether it is scalable in any way, partly because of what they conclude, which is they can only have, it cannot really be used in human beings. But even having said it's not necessarily scalable now, it may be scalable in the future, particularly if they find the right materials.
But then the other thing to bear in mind for the future, though, is if we're going to make this individualized to each individual person, what's that cost actually going to be? So as well as developing the technology, we need to develop the technology at a cost that we could actually afford.
Absolutely. And the sort of, certainly in British practice, the sorts of people who will have a testicular prosthesis will generally have it in the NHS and not in the private sector. And so we've got to think of exactly that, the practicalities as well. I mean, how do you arrange for someone to have a testicular prosthesis built, sterilized, certified as, properly medical grade, as it were, and then sent out to that particular patient? So yes, it's an interesting proof of principle paper, but I'm not entirely sure how it could be translated into practice. But then again, I'm sure people said that about all sorts of bits of technology when they first came through.
Really? Who knows what the future holds for this?
Yeah. Okay. The next paper is from Southampton again, and it's about trends in antibiotic resistance after E. coli positive urinary infections. Essentially, it's a paper looking at the resistance to E. coli to antibiotics, to commonly used antibiotics in this particular institution over a 6-year period, to see what the effect of the guideline-based antibiotic policy is on resistant patterns. Most hospitals have some kind of guideline, have some sort of antibiotic stewardship model. And this, of course, is therefore a very relevant paper as a result, because we all have these systems in our hospitals. They looked at sensitivities of E. coli isolates between 2014 and 2019, so a period of 6 years. And these were from the hospital and from general practitioners in the community. Now, they had a very, very large number of samples, 712,000 samples, which tested positive for E. coli. So the numbers are very impressive, to say the least. They basically, as the poster says, saw some increasing resistant trends and also some decreasing resistance trends over that period of time. But overall, resistant trends for Kefalex and nitrofurantoin and amikacin remained equivocal. So they basically stayed more or less stable. So some drugs went up, some drugs went down. The conclusion was that despite the guideline-based antibiotic policy, overall antibiotic resistance remained stable. There was an increasing trend in antibiotic resistance for more commonly used antibiotics, including things like tazocin and carmoxyclav and ciprofloxacin, which is what you would expect. They attributed the rise in tazocin resistance to the overuse in the management of acute sepsis. And they conclude that further emphasis should be made to educate the staff in relation to the use of this particular drug. The decrease in trends were attributed to a shift in prescribing preferences and prescribing practices, again, which is something that you would expect. And in the end, they basically plan to continue their policy of reviewing antibiotic usage and prescribing protocol with the microbiology department to minimize antimicrobial resistance. I think this was a good paper. I think, as I say, the numbers are so large that you can't but say the conclusions are probably valid. I don't think you can say they're not valid. I don't know what you do in terms of antibiotic stewardship in your trust, but I assume it's the same as the rest of us. You have policies that are published and guidelines that are published, and we're urged to follow them. And I assume in my trust that this kind of work is going on in order to provide a basis for those bits of advice locally.
I think the sort of concerning thing is the increasing resistance to gentamicin and tazocin, because they're the ones that we reserve for either our prophylaxis during surgery, and we just assume that that's going to help prevent any infections, or our septic patients that present via the emergency route. What we're going to do when we've got an increasing septic patients presenting resistant to these antibiotics. We haven't got really other ones in reserve.
It is absolutely a big concern. It's interesting, though, that they are, at least for some of the antibiotics, decreasing resistant trends. So hopefully they will pick up a little bit of the slack. But yes, overall, this is a big problem. But I think, it's a good paper to remind us all to use antibiotics responsibly.
Absolutely. And if any concerns or questions, phone your microbiologist.
Absolutely.
And this sort of links then with this, with the next paper, which is from the team at Bristol, looking at immunological markers in. Sorry, the screen's jumping all over the place. Immunological markers excreted in urine in response to urinary tract infections. So they wanted to try and evaluate the levels of a number of immunological markers present in urine in patients that had confirmed UTIs by specific bacteria, to see if they could find anything that was more better to use than the traditional urine dipsticks. They had 40 urine samples sent by GPs, and they confirmed these had either infection with either Proteus, Klebsiella, or E. coli, and looked for specific markers, which were interleukin 8 and 6, procalcitonin, lactoferrin, and uromodulin. And they found that the interleukin 6 and 8 and lactoferrin were present in higher concentrations in the urine of the patients that had the UTI caused by those 3 bacterial species that were mentioned. So could this then be used as a better test, as a better point of care test, to say that a patient has a UTI when you do the urine test, rather than then start the antibiotics rather than waiting for the urine sample to come back? I think this is done as an ELISA technique, so I don't know how long actually that would take to come back. So is it a point of care test?
Mm.
So this is something, again, is it a base point to work from to find, is there something more effective than a urine dipstick to say, does a patient have a true UTI that we could start urine antibiotics on straight away, rather than waiting when you've got that slightly ambiguous urine dipstick in a symptomatic patient, rather than waiting the 2 days for a urine sample to come back from the microbiology department.
Again, this is sort of almost, this is sort of lab work really, and is not necessarily immediately applicable to clinical practice. However, you can see how this sort of work would be very helpful in identifying who has a urinary tract infection, but even more importantly, tying it to the last poster, it might actually guide us as to which antibiotic might be best to choose. So if you know that, a specific immunological marker is associated with a specific type of infection, you might then be able to choose your antibiotic more wisely and with more direction. The other thing, of course, is microbiology or growing bugs in the lab and so on is expensive.
Mm.
So if this sort of work could be translated into a way of not necessarily culturing every single sample, because you have a high degree of certainty what you're treating just from these markers, then that would be also a useful thing. So I think it's very important work, and it would be interesting to see whether over the next few years it's translated into something clinically and practically useful in our day-to-day practice.
Yeah.
But yeah, good paper, I think.
Really.
Right. Our final paper is also from London. It's entitled "The Emergency Nephrostomy Insertion Out of Hours: Transfer to Tertiary Center or Wait for In-House Interventional Radiology Services." The implication in the title is that if you go to a tertiary center, you will get faster care, and that if you do something in-house, you have to wait for care. So let's delve into it. Essentially, Bowles guidelines recommend that we should decompress an obstructed infected system within 12 hours of it being identified. And many hospitals have interventional radiology services that are limited to working hours alone, hence the reason for looking into this question. So essentially, their aim was to assess the timings from decision to transfer, arrival at tertiary center, and percutaneous nephrostomy insertion, and also to determine whether transfer led to a nephrostomy insertion compared to whether it led to an earlier nephrostomy insertion compared to waiting for an in-house IR services. They looked at patients who were involved in a transfer from 2016 to 2019. And looked at the data relating to time of admission, decision to transfer, arrival at tertiary center, and nephrostomy insertion. They found 34 patients, and 10 of these were excluded because there wasn't enough documentation to include them in the study. The average age was 58, and the ratio was 2 females to 1 male. The average time from decision to arrival at tertiary center to insertion was 5.3 hours. Arrival at tertiary center to nephrostomy was 8.2 hours. Decision to nephrostomy insertion, decision for insertion to nephrostomy insertion was 13.9 hours, with quite a big range, 4 to 43 hours. They also then looked at curiously, Sunday to Thursday timing compared to Friday to Saturday timing. And the reason for this, as I understood from the paper, was because between Sunday and Thursday, in-house radiology services are available the following day, which seems a curious way of looking at things. And so, but if, for example, somebody comes in on a Friday, then there won't be anything available the next day. So there's an imperative to transfer on a Friday. In the end, I think the conclusion is correct, which is most of these patients should be optimized and treated on the basis of their individual presentation, and it should be done on a case-to-case basis. And finally, that transferring to a tertiary center does not necessarily lead to faster intervention.
Yeah, I mean, I agree with their conclusions that it needs to be on a case-by-case basis, depending on how the patient is. And the best thing to do might be medically optimizing and just waiting. It's difficult because they presumably transfer everyone to a tertiary center, so they can't compare anything to, we kept this patient and waited until we could do it in-house. So they haven't got a figure to compare their transfers to. But if a patient was waiting almost 2 days from decision to transfer to actually then get the nephrostomy, then that could be considered unacceptable.
Absolutely. I think it's a difficult situation for most hospitals because there's so many variables. Whether transfer is possible, whether beds are available at the tertiary center, who is available to do the procedure, other competing interests. So IR may be involved, say, in a vascular procedure, and the delay may be due to that. There's all sorts of things that compete with this. But also an interesting, for me, question would be comparing this to, or including those that required stents rather than nephrostomy in the equation, because certainly in my hospital, a significant number of patients with obstructing stones will have a stent rather than a nephrostomy, simply because it's easier and quicker in some circumstances.
I think stents, if you're working in a center that has interventional radiology, I think stents, in my experience, tend to get forgotten about. So for us, it's much easier to get a nephrostomy than it is to get a stent. So all our patients end up with nephrostomy, so we tend to forget about stents. But yeah, certainly stents should be readily available in these centres that don't have the interventional radiology.
So we missed that, Katie. You're frozen.
Oh, sorry. So I think in my centre we're spoiled because we have 24/7 interventional radiology, and it's actually much easier and quicker for us to get a nephrostomy than it is for us to get a stent. So I tend to forget about the stent option a lot of the time.
Yes, as I say, it is very variable.
Yeah.
We have probably a more mixed picture where I work. But anyway, getting back to the paper, I think it does highlight the problems that we all have in relation to those patients who come from outside. We've got interventional radiology 24 hours as well. But even in those circumstances, some patients still end up with stents because it's easier and sometimes just the right thing to do for them.
Most hospitals should have facilities to stent rather than transfer across a city for a nephrostomy.
Absolutely. It's still a good paper to at least demonstrate that the idea of transferring patients across town for a nephrostomy is not necessarily always the best one. And sometimes it is better to simply wait.
Yep. So that's all the posters discussed. I think to me the posters that stood out was the scrotal pain in ethnic minorities, and the ones that sort of looking at for more future innovations and the immunological markers in UTIs and the 3D printing for testicular prostheses.
I would agree. I think those three particularly were good papers. The ethnic minority testicular pain one in particular, because of its importance in normal day-to-day practice, and the other ones for the reasons you mentioned, that they present an exciting glimpse, as if you like, into the future. Thank you very much. I think that's the end of our presentation.